Hi, in today's lecture, we're going to cover bipolar I disorder and everything you need to know for your exam. So, as always, let's start a lecture with a question and see if you can answer this question correctly. A 40-year-old woman with a long history of mood instability presents after a suicide attempt during a depressive phase. She has had prior manic episodes. Which treatment reduces suicide risk in such patients? Lithium, valproate, carbamazepine, or quetiapine. If you cannot answer this question, don't feel bad. You're not alone. You will definitely know answer to this question, anything related to bipolar I at the end of this lecture. So if you're struggling to remember the difference between mania and hypomania, trust me, you are not alone. Bipolar I shows up everywhere, in exams, EOR, and on a PANCE, and usually confuses everyone, but not after today. In this video, we'll break down everything: symptoms, diagnosis, treatment, we'll go over exam tips, so you will never miss a bipolar I question again. So let's make this one stick. So what is bipolar I disorder? It is a chronic mood disorder defined by at least one manic episode lasting 7 or more days. That is important. So a lot of the topics in psychiatry will be very closely monitored by their duration. So knowing how many days, months, or so forth is very important. So for bipolar I disorder, they has to have a mania, which is lasting 7 or more days, or require hospitalization. Often, a bipolar I disorder will be alternating between elevated moods, such as mania, and with the major depressive episodes. Mania involves extreme mood elevations, impulsivity, and functional impairment. So they may tell you they're unable to work, they quit their job. So functional impairment is huge for bipolar I disorder, and it helps differentiate it from most other psychiatric symptoms. So epidemiology: onset is typically in the late teens or early adulthood, affects men and women equally. So the disorder often causes significant functional impairment or psychosis. The mnemonic for mania to remember is dig fast. This is going to help you remember what mania presents with, and when it comes to dig fast, according to DSM-5 bipolar I disorder criteria, using dig fast, they must have a one manic episode. It's a distinct period. What is a manic episode, right? So this is a distinct period of elevated, expensive, irritable mood and with increased energy that lasts greater than 1 week, or any duration if the patient is hospitalized, if they're, causing harm to themselves or the other. So hospitalization or lasting greater than 1 week, think of mania. And during these episodes, you will need 3+ symptoms, 4+ if mood is only irritable. So dig fast covers distractibility, so they easily sidetrack, they trouble focusing. I stands for indiscretion. They have risky behavior. They're spending money that they don't have, or just spending money that they shouldn't. Sex, driving, etc. G stands for grandiosity, inflated self-esteem, feels powerful, important, feels like a superhuman. F is a flight of ideas, racing thoughts, rapid topic changes. A is activity increase, is goal-directed activity, psychomotor agitation. S for sleep deficit, they have decreased need for sleep and still feels rested. And T is for talkative, pressured speech, hard to interrupt. Dig fast, distractibility, indiscretion, grandiosity, flight of ideas, activity increase, sleep deficit, talkative. You need 3+ of these symptoms, and they should be lasting greater than a week or patient is hospitalized. That is according to DSM-5. So let's get back to our description epidemiology, and I always advise people to come up with some kind of memory hooks, mnemonics, or so forth. And to be very honest, guys, some of these I've been graduated about 6 years now, and I still remember these. And the rest of the material is a lot of times just blur. So for bipolar I know it needs to last 7 days, so that's a week. And I remember it as one bipolar week. One manic episode defines it, lasting a week. One bipolar week. Exam tip for this: the mania is the key. Mania differentiates it from bipolar II, from MDD, from schizoaffective disorder, and so forth. Don't confuse with bipolar II disorder. It is a disorder that requires hypomania and depression, but not a full mania. Major depressive disorder will lack the manic episode, and schizoaffective disorder, you'll see the mood symptoms plus psychosis, but psychosis persists without the mood symptoms. So do not confuse bipolar II, MDD, or schizoaffective disorder with bipolar I disorder. Bipolar I lasts a week, and it has mania and mood symptoms. Causes. So what causes bipolar I? It's usually a genetic predisposition, which is high heritability. So always ask for family members that may have some other psychiatric issues. And is also caused by neurochemical dysregulation, usually dopamine, serotonin, and norepinephrine imbalance. Also, stressful life events can trigger the episodes of bipolar I disorder. Exam tip, as I already said, family history is often positive for mood disorder, hospitalized if a manic behavior possesses safety risk. Memory hack, too much dopamine, too much drive. I mean, that's simple. Give them too much dopamine, they may do some crazy things. Don't confuse this with ADHD. So ADHD, you're going to see persistent hyperactivity, but without the elevated mood. What they're going to present with. So let's talk about clinical presentation and physical exam. So the manic episode will present with the symptoms of that dig fast, elevated or irritable mood, decreased need for sleep, grandiosity, talkativeness, distractibility, impulsivity, and risky behavior. Possibly they may present with the psychotic features during mania, which are delusions and hallucinations. So look for that in the stem. And then they will definitely present with some functional impairment at work, social life, or self-care. So exam tip is mania must last greater than 1 week or require hospitalization. Don't confuse their presentation with hypomania. They will have milder symptoms, no psychosis, usually the biggest differentiator. There's no psychosis in hypomania. In hypomania, you'll see a lasting greater than or equal to 4 days, but never more than 7 days. In schizoaffective disorder, you're going to see psychosis persists outside of the mood episodes. And let's talk about this in a little more detail to really differentiate mania from hypomania. So, in mania, as we discussed, is going to last greater than 7 days or any duration if hospitalization is required. Severity is going to cause marked impairment in their social or occupational functioning, and for that, they may need hospitalization as well. Psychotic feature can be present. Look for delusions or hallucinations, high elevated mood lasting greater than 7 days. Energy and mood, they're going to be extremely elevated. These people are going to be irritable or expensive. And examples, they will be like they quit their job impulsively, they're spending thousands, they believe they have superpowers, and so forth. So, exam tip is look for psychosis or hospitalization that would equal to mania. Memory hack again, mania is a major impact on life. Mania, major impact on life. Let's talk about hypomania. So hypomania will have duration that is equal or greater to 4 days, but shorter and milder and never greater than 7 days. Severity, there will be no marked impairment. They can still function at work and home just fine. Psychotic features will be absent, and their energy and mood will be elevated or irritable, but they will be able to control themselves. Others may just think this person is overly confident, overly productive, or something. They will not exhibit symptoms of mania, and it's just they're still functioning, but it's lasting 4 to 5 days. And examples would be increased energy. They're talking more. They staying up late working. They have that increased social charm and so forth. So exam tip: if functioning is preserved, think of hypomania. If their functioning was affected, that would qualify as mania. So after this slide, you should never mistake mania and hypomania again. Moving on, so just a quick information guide. This is a great time to tell you this lecture comes straight from my PA EOR study book, in which I cover every content just like this with exam tips, with do not confuse with the memory hacks, step-by-step approach for each disease from the blueprint. I think there's 57 of them. And also at the end of it, there's 120 exam style questions, just like an EOR, to help you boost your score, save time studying, and spend that time with your loved ones. Let's move on. Treatment. Let's talk about treatment for bipolar 1. So the major treatment would be lithium. It is a gold standard. Valproate and carbamazepine are also used. Atypical antipsychotics such as quetiapine or olanzapine can be used for acute mania. These patients will require hospitalization and combined therapy. And psychotherapy is adjunctive treatment, not the first line. So exam tip, lithium also reduces the suicide risk and stabilizes mood the long term. So if I think bipolar 1, I'm thinking lithium. Also, exam tip, never use antidepressant monotherapy because this can trigger mania. And a memory hook that I finalized at the end is my mood is flipping. Now I'm elevated, now I'm depressed. It's been happening for over a week. And I say, bipolar weak, bipolar battery, and only lithium charges it right. I think of lithium battery when I think of bipolar 1, and I know bipolar 1 is 1 week, so 7 days, bipolar battery, lithium charges it right. Let's talk about lithium in a little more depth because this is the test creator's favorite to test. I've seen questions on lithium left and right throughout our school. So it is a first line mood stabilizer for bipolar disorder, both acute mania and for the maintenance. This is an important one too. They're going to be testing about narrow therapeutic index. So we got to monitor the serum levels. And the normal level should be between 0.6 and 1.2. So they're going to give you numbers. They're going to ask you if this is within an index. So if you know zero point 0.6 to 1.2, it's normal. Everything outside is outside of therapeutic index, and we should make some changes. So if it says greater than 1.5, that is toxicity. Renally excreted. So lithium gets filtered by kidneys, so you should avoid this medication if there's a significant kidney disease. So we should always check kidney functions before use. A question can ask you before starting lithium on this patient, which lab should be tested, and that would be BMP. So side effects of lithium: tremors, hypothyroidism, nephrogenic diabetes insipidus, and weight gain. Another big side effect of lithium is that is teratogenic. It can cause Epstein anomaly risk if used in the first trimester. So they can get creative and say the baby was born with Epstein anomaly. Which of the following medication was taken by mother during the first trimester? In that case, answer would be lithium. So also, it's good to know that it interacts with NSAIDs, ACE inhibitors, thiazide diuretics because it increases the risk of toxicity. This can come handy if you're on your rotation and you're thinking about putting the patient on lithium, but you find he's taking some of these other medication on his chart, so you want to talk to your preceptor about the other medication and what they see before they approve on a lithium. That will make you look like a good student and you will do great on that rotation. And what are the toxicity signs of lithium? Coarse tremors, ataxia, confusion, GI upset, and seizure. And another way that I always remember the side effects of lithium would be mnemonic that we will cover here in a second. It's called just lithium. But before we jump into that, let me give you another exam tip. Since they will always ask about lithium side effects, make sure that you screenshot this one or something because you will definitely come across from it. And when it comes to all the medications, they are covered at the end of the book, so you will find all the side effects and everything you know about psych meds. So the lithium side effects, the core mnemonic is actually lithium. L stands for lethargy, I for increased urination, T for tremors, H for hypothyroidism, I for impaired cognition, urine retention, and M for metallic taste. So if they want to get creative, they can tell you patients taking lithium, these are the side effects, and they would say which one of these side effects is not related to lithium. So you would just rule out the three that are in a lithium mnemonic, and the one missing is the correct answer. So lithium toxicity, you will see it if the narrow therapeutic index is greater than 1.5. And memory hook for lithium, besides the lithium mnemonic, I would say lithium makes you slow, shaky, thirsty, and heavy. All right, so the high yield facts: bipolar 1 requires greater than one manic episode. Mania has to last greater than 7 days or need hospitalization. Lithium is the first line mood stabilizer. It also decreases suicide risk. Manic episodes can have psychosis. hallucinations, delusions. Suicide risk increases close monitoring is needed. So exam tip is manic episode is a hallmark. Don't miss the psychosis or functional decline. Any of those present, you should be thinking bipolar 1 as your answer. And back to our question. So, 40-year-old woman with a long history of mood instability presents after a suicide attempt during the depressive phase. She has prior manic episode. Which treatment reduces suicide risk in such patient? And answer is lithium. So it's the only one that prevents anti-suicidal behavior in bipolar 1. Giveaway is lithium, life-saving mood leveler. Uh, valproate is effective in mania but has nothing to do with the suicide prevention. And C and D are just not the first line medications in this patient. All right, that's the end of the lecture. Thank you, guys. I advise you to check out a book. It is on Amazon. You're going to love it. It's going to help you save time. And as always, I'll see you guys in the next video. We're going to cover bipolar II, major depressive disorder, and we'll basically cover all the steps through the psych sections. Have a nice day, guys.